Hey, thank you. Thank you, Jake, and the organizers of this session for inviting me here, which is makes me quite nervous for various reasons. So first, I'm not a liver pathologist. I know the liver is the big brown thing when you do an autopsy on this side. And once in a while, I have to sign out a liver rejection on call, and that is also where you phone your liability insurance before. So I really appreciate it that you give me a chance to speak here, but also on behalf of the Banff Foundation, I hope you enjoy your meeting here. Right, we brought all the trees in extra for this meeting, and we're celebrating, as you know, 30 years of the classification. The building next to this building is where the very first Banff meeting was held in 1991, and I think, Jake, were you there? No, you were at the third one, right? So the liver group is the second oldest Banff group since 1995, and thank you, Jake, for keeping that area in check. And it's interesting listening to your problems. So the kidney and the liver, at some point they share similar problems. So it was ABMR at a certain time, and now you talk about long-term survival and residual infiltrates. And we just had the kidney session this morning, arguing, like in old good days, as Agnes Fogel says, heckling, about what do you do with chronic infiltrates? Is this still chronic rejection? No, every native kidney has it, so it isn't it. So the same challenges with longer graft survival, we see different pathologies. So then, Jake, you asked me invasive monitoring comparison of different mRNA expression profiles. Well, when I got that title, what I'm going to do here, and it is really daunting, but I will try to give some or share some of my thoughts. Here are my disclosures. And I'm pro-Banff, I'm pro-biopsy, and I work for Sandy on a part-time as well. So why would you do invasive monitoring? Because, and that I learned from Phil Halloran, follows Sutton's law. Who knows what Sutton's law is? You don't know? Yes. Yeah, Willie Sutton was a notorious bank robber, and when he finally got caught and said, "Why did you rob all those banks?" he said, "That's where the money is." So why are we doing all these biopsies? Because the truth is in pathology and is in the tissue. So that's what I took away when I did fellowship with Phil Halloran. And of course, I'm German, and Phil Halloran always cited Rudolf Virchow, but he couldn't say which was quite entertaining, of course, so for us Germans in the room. So Rudolf Virchow is, as you know, the first official anatomical pathologist who used the microscope to define cellular pathology and said normal cells, abnormal cells, hence association with the disease. So he introduced anatomical pathology into medicine. And the biggest hospital in Berlin is named after him, right, or the second largest. And of course, everybody knows who Robert Koch is, so Koch's postulate. But the work, of course, was done by the young postdoc on the right in the lab of Virchow, yeah, which was Friedrich Cohnheim, who described the first, essentially, pus, abscess. And when you opened an autopsy at that time, an abscess, and there was all the juicy, good stuff coming out, it was revolutionary to say that the bacterium caused this pathology and not some juice or higher force. So the association when you have an infection that the white cells and the tissue destruction through the immune response are actually pathogenetically connected. And that was the fundamental discovery they established and published in the literature. And I think we have made some progress from that concept that when something doesn't work out, inflammation kicks in. Or are you still arguing about the question whether there is a relationship between inflammation and in the tissue? But there are problems with Koch's postulate, and as you all know, it's not 100% strict, right? Certain agents which cause the disease, when you transplant them into a different scenario, the phenotype can look differently. Not every therapeutic intervention reverses to the original state, but you have partial responses with different phenotypes, right? And that is, I think, what we deal with in pathology, in transplantation here. So there is no normal in transplantation. transplanting an organ is not normal per se. Donors go through intervention, brain death, worse things. Recipients don't want the graft immunologically in general. And we do enormous interventions on a chronic basis as maintenance immunosuppression, which interferes with side effects. So there is no, it's very hard to say what is the normal controlled environment here. And then on the molecular level, we think, okay, cancer, why can't we just do it? We measure one molecule, we have a drug, and we just solve it all. And I showed this slide yesterday. Really, that's the success story of molecular diagnostics in tissue. You find the one really pathogenetically driving molecular change. In this case, it's the EGFR, famous EGFR mutation in melanomas or glioblastomas or lung cancer, which you can target with a drug and you reverse it, cost postulate, to the original state. You make the tumor go away. And that doesn't work in our world because, as I said, as we're just handling the inadvertent balance between rejection and infection at the immunological level. There's probably no way around it. Wait, tolerance is around the corner, isn't it? For a while. But maybe we achieve full tolerance and recognition and acceptance of the graft one day. But as long as we're not getting there, we will have to deal with titrating the inflammation the transplant causes in the host. So that is where Banff kicked in. As you all know, I can summarize this quickly. We just established thresholds for saying when you should increase immunosuppression or you should decrease. So when you have severe infection coming back, you better give less immunosuppression. But when you have rejection, you give more. Fundamental concept. And we know there is a linear relationship between time and uncontrolled scenarios and the allo setting. Inflammation grows and inflammation destroys the graft. And these are mouse models for kidney, but you can look at primates when you do not, the control groups which are not immunosuppressed. We know what the natural course of rejection is and how inflammation handles an allograft. But we know, and this comes back also to the limitations of cost postulate, that the pathology associated with that is not specific, right? BK nephropathy in the kidney looks the same as rejection, T-cell mediated rejection. Recurrent hepatitis, at least when I was looking at liver biopsies, remained a diagnostic challenge to T-cell mediated rejection, right? And although we understand the mechanisms of antibody mediated rejection in the kidney and in other organs across the organs of HLA, anti-HLA antibodies are binding through the HLA molecules expressed usually in the microcirculation. We know that other diseases potentially, especially in the kidney, but also in the lung, can cause similar pathology. So Banff tried to summarize this up with its lesions, combinations, and grading. And I think this was a good benchmark and a good compromise and allowed us to test drugs, and we improved long-term allograft survival, and now we're seeing different pathologies, right? When there was no benchmark for T-cell mediated rejection in the kidney, ABMR, so to say, didn't exist. Of course it was there, right? There were always DSA. DSA were not invented post-calcineurin inhibitors, that's not true. And we just learned to discover it while TCMR became more controlled. So now, solving this conundrum, the big hope is with molecular studies, and I'm part of my existence as working in this. And as you can see, a major driver of using molecular tools is, and the number of publications are going up, but it's technology, right? We should not forget that we now have tools we did not have 20 years ago. So Phil's talk yesterday, he said he studied molecules for over 20 years. He started with northern blots. How would you do a whole genome expression profile with northern blots? I'm just imagining that, how many, you need 24,000 postdocs probably, right? And they all do one northern blot. So or they can do two. And the evolution of these technologies is just record. And it's not only high throughput, but it is, you make specimen types accessible, which were not accessible in the past. You get different resolution in spatial context, and I will allude to that. And you can essentially, when we go back to Koch and Virchow, where they look mostly at gross pathology, really autopsy was the big thing at the time. You cut it open, you saw what, just for pathology, you saw wonderful pathology is that exists for people outside the room, right? But you could see where the disease operated in the organ and destroyed it. And then when endoscopy came in, right, gross pathology was more pushed back, and we went to needle core biopsies or cell aspirates. And then we realized, okay, for the microscopy, you need at least an 18-gauge needle biopsy. But now with these molecular tools, our cytopathologists, and in Pittsburgh as well, they get 15 cells from a thyroid cancer, they tell you which mutation is in there, you get your drug, minimal invasive, ambulatory done, ultrasound guided, right? So you can now apply these very comprehensive tools to very, very different cell specimen types. But what we learned from Phil's work is, who really comprehensively studied numerous transplant biopsies at the whole genome scope, is that there is a coordinated pattern of gene expression aligning with the pathology. And especially with inflammation, this is a landmark paper here by Thomas Müller. The more I-score you have in the biopsy, the more T-cell transcripts you measure. Fundamental relationships, and it's really about now to learn how these relationships can be used to inform our clinical decision making. So when you talk here about inflammation as being your major problem, which I assume, is you will find, and my predecessor speaker here showed some reference to the liver studies of this, is you see these interrelationships of the inflammation in the biopsy with the gene expression. However, then when we understood that, we went back and asked, how do we score inflammation? Of course, it depends how you generate the I-score and score it when you do the correlation with the gene expression. And there are, at least in the kidney, but also in the liver, you have different types of inflammation. But when you grind through the whole core, you don't know whether the T cell is centrilobular or periportal or in a bile duct. And they are just T cells. They are going in this whole overall expression profile. And that was a big challenge, or it still is, in liver, in kidney as well, and especially also time of the biopsy. We realized that different inflammatory patterns arose with time post-transplant, and the spectrum of inflammation and histology changed. And that was also reflected to some extent in the gene expression profiles, with B cells and immunoglobulins being more prominent in late biopsies, and the classical cytotoxic T cell transcripts in early biopsies. However, now that we can access native kidneys and archives, Ben Adam from our group did a study comparing different types of interstitial nephritis in kidney, in transplants and in native kidneys. Those induced by checkpoint inhibitors in transplant and native kidneys, and they significantly overlap, right? So maybe the mundane generic T cell doesn't really know why it's here today. It was just called and it showed up and does what it used to do. So I'm a cytotoxic T cell, somebody ordered me here, I release granzyme B, I'm done. Wouldn't we do the same thing, right? You would not worry about why you're here, right? So kind of human down to the cellular level. And also when we compared BK in native kidneys, which should really not reject a native kidney, right? With T-cell mediated rejection in kidney transplant, the only significantly different transcripts are the polyomavirus transcripts. Duh. Well, okay, thank you. Another couple of $1,000 for nothing. So this is a really nice review by Phil Herron of showing what we know about molecules. And I really, really like it because it is so, this graph is just so summarizing it so nice. There are transcripts, and pick your favorite up here, strongly associated with T-cell mediated rejection. There are transcripts, pick your favorite. My favorite is dark, just to share with you, which are associated with antibody mediated rejection. And then we have mixed rejection, they overlap. Isn't that amazing? And maybe a lot of people have mixed rejection. I know we love, especially pathologists, and you know what? I'm a department head and I have 100, and they all love boxes. No, the case has to go in here. It can't be two things, right? So, but maybe that is not what it is. And Phil showed this nicely. There is overlap, and he really put a lot of effort, energy, and resources into studying the molecules. There is this inevitable overlap. So the question is this lack of precision in the molecules, or is this the truth of the disease we deal with? So is there such a thing like Koch's postulate, where you can have one thing and it must be one phenotype and you intervene? So is this really sustainable? Or when you have had a liver transplant for 25 years, maybe there is more than one disease process going on. And of course the math, don't forget that when you work with high dimensional molecular data, the bioinformatician is a post-analytical component, and every lab test, the result depends on the pre-analytical component, the analytical component, and the post-analytical component. Pre-analytical, when you put acid into the RNA, your analytical component is not working. So a bad sample, dried out, destroyed, right? Pre-analytics, as important as having your machine calibrated, running the assay, knowing your probes are hybridizing to the right target. And then post-analytical, cleaning it up, taking out noise, right? It's normal, you do this in all lab tests. But the bioinformatics is a post-analytical component which has as much influence on the result as any pre-analytical component. Don't forget that. And it's very nicely shown in this paper. So despite all these limitations or gaps of understanding, there's many tests now out you can buy or you can commercially utilize, whatever the term is. And the AST and the ASTS did a consensus conference reviewing them all and saying, can professional societies endorse these or recommend these? And the outcome, I think, to this point was, no, we can't, because, and that is this column here, we're really not sure how to use them. And what do we do with them to improve and manage patients in an evidence-based way, according to current standards of mostly regulatory bodies and also reimbursement bodies in various countries. So at that conference, I gave a similar talk, and as I said yesterday, Dori Sagiev, who some of you know, came up to me and said, so what, Michael? What are we doing with this, right? So the so what question from a lot of invasive molecular testing remains. There's interesting research questions, but before you do and change something with your patients, you may want to ask the so what question. And as we said to all trainees, don't order a lab test when you do not know what to do with the result. It might be positive, and then you have to explain that to the patient, right? When you just ordered random lab tests. And 5% of all lab tests are per definition false positive, right? Because they're based on confidence intervals. But acting on a overpromised or in the wrong context used lab result can do harm to patients. And I think that's the most important thing to take into consideration. And the other challenge is, even if we would have the perfect marker for antibody-mediated rejection, right? We have no real treatment yet. So we could use it to design trials, but we could not give any treatment recommendation in the clinical context, because there is no validated treatment, even when you know somebody has antibody-mediated rejection. So where we want to go with Banff in these, as I showed yesterday, is really to think of how can communities invasive molecular testing for clinical purpose validate better. And I went through this at Extensio, but I think it is now knowing all the technology and understanding the science behind it, the community can start designing clinical trials for the right clinical context of the question. And as I said, I'm not a liver pathologist, but I'm sure there's smart enough people here in the room who can do this. And as I said, there's various tools available. The BHOT panel reflecting the most common genes, which is cross-organ, And you can use it on archived samples, and I know that your community of liver transplant in North America, Jake, you worked with this, has done many, many well-designed clinical trials of weaning, of intervention. You can go back to all those paraffin logs, right? And you can do a randomized molecular endpoint trial backwards and test the arms for their differences. And you don't have to use the VR panel, you can design whatever genes you want. But you have a golden opportunity through all the NIH trials, I think, to ask a really research question and then compare the groups molecularly, and that could inform at least the design for next generation prospective trials. So that is the concept which is behind this consortium of using the same molecular technology and making data comparable, which you can normalize against each other and between centers, and you can compile the one trial to the other and take arms out and compare them, so you create a richness of data which allows us to simulate in silico, hopefully, when we have compiled them, the scenarios we want to study. You can do online tools, and that has been done in other areas for normalization, as I said, where you can make data comparable, you can build classifiers there. So you don't have to be alone, and we just talked about various of these initiatives at this meeting. So at the end, I think we will add molecules as we have added other technologies to render diagnosis. So I think there was large consensus